Hello, everybody. I'm a professor of translational empowerment at Copenhagen University, and I'll tell you about a new theory about person-specific insight. It is a pragmatic grounded theory, and person-specific insight is an empowering output of using the method guided self-determination. On the way to developing guided self-determination, a certain case showed us the power of person-specific insight for the first time. It was in a case of an old woman who had stopped eating and drinking. She was admitted from a nursing home, dehydrated and difficult to contact. Her daughter joined her. After intravenous fluids, she was awake again. Psychiatric supervision concluded that she was not depressed. Then a third-year nursing student was given the task to finding out why she had stopped eating and drinking. She asked this question: what really happened when you stopped eating and drinking? The question enabled the woman to respond in time and place and literally invite us into the space and situation where she made her decision. I'll tell you, I live in a nursing home. When we eat, I always sit at the table at the window in the dining room. At that table, there are also two men. Now I eat very slowly, and every day they teased me with it over and over again. One day it just became too much. I couldn't stand it any longer. I simply stopped eating and drinking. We couldn't guess that kind of knowledge, so we think it is an important knowledge. I'll tell you a little about guided self-determination, and because this kind of insight appeared to be a systematic output of using guided self-determination. It is an empowerment and evidence-based method and for reflection, collaboration, and change. It was developed in 2004 in complex diabetes. It draws on GSD, reflection sheets, and advanced professional communication. Researchers decided to investigate this kind of person-specific insight further through a systematic output of DSD seen in 20 DSD interventions in long-term conditions in Denmark, Norway, Sweden, and Australia. DSD was used in very different doses across the conditions, from one sheet with unfinished sentences in one dialogue to 20 sheets in 8 dialogues. Empowerment-based method seems to be needed because challenges in life with a long-term condition are so diverse and concrete that professionals cannot guess their nature. And that happens, for example, in a young woman who had diabetes and works in a bakery shop. The nurse thought that the woman knew all about healthy food, which she did. Part of her job was, however, every day to taste if the cakes were fresh enough to be sold in the shop. Completing DSD reflection sheets, she discovered that she did so without being aware of the influence on her blood sugar. The nurses valued the power of this person-specific insight. One nurse said, "I thought I knew her, but it turned out that I didn't know her at all in that way. In one of our first conversations, something dawned on me, and I thought, now I understand her better. What's happened is that she herself put it in words, that we've come up with some problem areas that have become clear to her. It was a mess before." The 4-step theory of person-specific insight starts in the mind of the person. By completing written reflection sheets, the person gains new self-insight, discovers what is important in life, and which actions or omissions might threaten the values. This self-insight mobilizes relational capacity in the person, becoming ready to talk about own challenges. And this paves the way for the next level, person-specific insight in a supportive relationship. Here, the insight becomes a shared insight about what really is challenging in the person's life. This mobilizes relational capacity for mutual problem solving. Moreover, it paves the way to the next level, person-specific insight in the interdisciplinary team. At this level, person-specific insight constitutes a kind of empowering evidence, which mobilizes relational capacity in the team with ability to make decisions across professions, sometimes causing change of treatment. The last level, the person-specific active role in writing, drawing, and talking increases the ability to communicate. Hereby, person-specific insight moves to daily life, where the person becomes ready to involve other people in overcoming the challenges. This increases readiness to accept support from others and will hereby decrease loneliness with the condition. This slide shows which conditions the people had who provided examples from the interventions. It was diabetes in different age groups, breast cancer, gynecological cancer, endometriosis, fertility treatment, schizophrenia, ADHD with comorbid medical disorder, end-stage kidney disease, adults with diabetes or pre-diabetes in DPs, and people diagnosed with or at risk of chronic obstructive pulmonary disease in DPs. Also relatives took part using DST in some interventions. It might be related to adolescents intervention, being admitted to an intensive neonatal care unit with a premature infant, and as a spouse to a woman being treated for breast cancer. We see a large potential in person-specific insights. With methods enhancing patient reflection, person-specific insight can be created at hospitals, in general practice, or in the community. Being exchanged between the three, person-specific insight will enable us to establish a coherent healthcare system. I'll finish by suggesting that implementable and sustainable programs are developed with the aim to systematically create person-specific insight. Comparison of such programs should include the ability to create person-specific insight, which can be seen as part of relational empowerment. And that was the end of my